questions. So next up is Dr. Opondo. He is the head of the Department of Psychiatry at the University of Botswana and an adjunct assistant professor of psychiatry at the Perelman School of Medicine at the University of Pennsylvania. I just want to remind everybody that in your booklets you have full bios for everybody that's here today. So that's what I'll say about Dr. Opondo now. You want to come up?
Good afternoon, colleagues.
Good afternoon.
Yes, it's a pleasure to be here to share with you my experiences or our experiences, because we work as a collective in developing a psychiatry residency training program in a resource-limited setting, which is specifically Botswana. Now, maybe let me start by saying, when we say resource limited, it's a relative term.
Right.
Yes, so you can put any meaning to it, but there is no one standard that says maybe resource limited setting is having either 5 lecturers or having $1 million or so on. It's just like saying a lot of people think of Africa as one homogeneous continent, and yet the differences are so many and vast. So I think to start off, maybe we should see the setting that we are talking about. That is Botswana. It's a neighbor to South Africa, and it's bordered by Zambia, Namibia, Zimbabwe, and South Africa. The capital is Gaborone. Incidentally, the capital of Botswana used to be in South Africa. By that time, it was called Botswanaland, and it was in Mafikeng. And so, maybe just some background on the organization of health services in Botswana. They're usually two-tiered. We have community-based and facility-based services. And the community-based health services are run by district health management teams. The facility-based services have to keep turning this way and that way so that there's no discrimination. The facility-based services are organized in a hierarchical manner, with the mobile stops at the bottom of the ladder. And from mobile stops, you go to clinics, and then you go to primary hospitals, and then district hospitals. And then at the top, we have the national referral hospitals, which are 3, and 2 of those are general hospitals, and 1 is a psychiatric hospital. 1 national referral hospital is a psychiatric hospital, which is called Sibran, and we'll talk about it. And let me also just give you some brief history of psychiatric services in Botswana. Like almost everywhere else in the world, most of the initial services were custodial in nature, and patients were usually sent to South Africa and to prisons in South Africa. Maybe South Africans might know a hospital called St. Helena. I don't know whether it was on St. Helena Island in the Atlantic. And others were being sent to Ingutsen in Zimbabwe. And then in 1936, they opened the first prisons in Botswanaland, as Botswana was then known. And then that would be said to be the first steps towards establishing a mental health service for the country. Because in 1938, they then built some rondavels. East Africans, we don't know what rondavels are. I'm an East African. You might not be familiar with what rondavels, but the South Africans know what I'm talking about. So they constructed rondavels to house dangerous lunatics in the prison then at Lobatse, where the psychiatric hospital is currently located. And then in 1946, the first unit was specifically built to house dangerous lunatics. You know, the word lunatics has a long history. And then from there, the movement started towards hospital-based services, and in 1969, that is the first time the country ever had a psychiatrist. And it was an Italian psychiatrist called Dr. Giuseppe Cibrana, and the current National Referral Hospital for Psychiatry is called Cibrana Psychiatric Hospital. And so, before then, all the services were basically based at the hospital. The psychiatric services for the whole country were based at the hospital. But then in 1978, that's when they started now moving services outside the hospital. They opened some community-based service about 500 kilometers from the hospital. And then progress has been getting better and better. And in 2010, they opened the first national, a new national referral hospital, which is 300 bedded, called Cibrana, as I've said. Now, again, some background on the history of training of doctors in Botswana. Initially, recognizing the need to have doctors, the government was training all its doctors outside the country. And the majority went to Ireland, Australia, South Africa, Norway, and Ghana. But then, by 2010, they had diversified that to around at least 17 countries. And they were sending out about 80 students annually. Now, you would think that for a country with a population of around 2.3 million, somehow I don't know whether Botswana are not reproducing because it has stayed around 2 million forever. Now, the last census was just this year, and the country the size of Kenya, Texas, and France has a population of 2.3 million. So the problem was, with this big number being sent outside annually, they were consuming the major portion of the Ministry of Education budget. And the third thing was that the majority of the students sent outside to study were not returning to the country. Only about 10% were returning to the country. And so a decision was then made to train doctors locally. And consequently, a medical school was set up in 2009. And they started with undergraduate training, but then the following year, in 2010, they started having residency programs. And as usual, nobody thought of psychiatry, and so psychiatry was not among those programs that started then. And all these residency programs, except for public health and family medicine, were what we call sandwich programs. The students were spending the first 2 years in Botswana, and then they are sent to South Africa, our big brother, for the rest of the training. Again, this was thought not to be optimal. And so, I'll talk about that on another slide. What was the situation regarding psychiatrists and mental health providers generally? When I went to Botswana, which was around, no, I won't tell you, I don't want you to guess my age. So, when I went to Botswana some years ago, we were 3 psychiatrists in the country. And of the 3 psychiatrists in the country, 2 were Kenyans and 1 was from Bulgaria. And the bulk of mental health services were being provided by community mental health nurses, and then other health personnel provided mental health care. And the first indigenous Botswana psychiatrist, Botswana is the name for the citizens of Botswana. Only returned to the country in 2008. And by 2011, Botswana had only one psychiatrist per 400,000 against a global average in the third world of 9 per 100,000. But then, in 2018, there were only 2 Botswana, that is indigenous Botswana or citizen Botswana practicing in the country. And both of them were in Gaborone. So that has been the situation about psychiatrists in the country generally. So when it was thought that it was time, at least psychiatry was also thought of, and there was need to develop a training program in psychiatry, we had some advantages, unlike the other programs which had to start from zero. We were not starting from scratch. And some of the strengths that we started with were, we already had an established university where the training could take place, and we had an established psychiatry department in the university because they had to train undergraduates in psychiatry. And we had a relatively big psychiatric referral hospital, the Sibana hospital that I've talked about, and we had what we call a teaching health system. Teaching health system was when the university started, when the government decided to start a medical school, then they roped their facilities into becoming teaching facilities for the medical school, so that every district hospital and the major referral hospitals, one, there was a joint service agreement where government doctors would train students from the university, and then university doctors would also provide service to patients. And then also the hospitals would provide infrastructure, physical facilities for the training of students and also for the classes if need be. And then the University of Botswana has one of the best libraries in Africa. So they brag, I don't know. And then we also had an advantage in the sense that psychiatry is relatively easier to set up in terms of physical equipment. We had a very well developed IT infrastructure, and we already had a template for the setting up of residency programs. We were going to copy from the pioneer programs. So that's what I've been talking about. We already had the University of Botswana there. The second major advantage, apart from those other ones, which is the teaching health system, is that we had facilities in the National Psychiatric Referral Hospital reconfigured to take into account the needs of teaching and our students. So we were given a whole floor, third floor of the hospital, which was given to the Department of Psychiatry. So that's where we have offices for the Department of Psychiatry there. We have a library, specifically it's not a hospital library, it's a library under the university, but we were given the space by the government facility. And this has been very helpful. The university dealt with supplying the IT infrastructure on that floor. And then the school for training nurses, the nursing training school, which is just adjacent to the hospital, also provided hostels so that when students, because the National Referral Hospital is around 70 kilometers away from where the university, main university is, away from the capital. So we were also given boarding facilities for our students. This is a hostel. Prof. Bonga has been there. It's a very big hostel. It's very huge, but don't tell them what's inside. It's very nice physically from the outside. we had those advantages, but we also knew that we were likely to face challenges. And fortunately, we could learn from the challenges that the medical school had faced on being set up. And what were these challenges? When the medical school was set up, within about a year, already there was a high attrition rate of academic staff, for the simple reason that government salaries were higher than university salaries, and that caused a problem. People came in, okay, you have this passion, you want to be an academic, and then you realize, academia is not going to pay your bride price, so you go and you weigh your financial options and decide, no, I'll go where they pay more. So a lot of staff left. And there was inability, consequent to that, to attract staff generally, and staff of high academic quality. But then this was then surmounted by the university, through the coercion of the government, agreeing to set aside a separate salary structure for medical school. That has earned us quite a number of enemies in the whole university, because the medical school has got a very different salary structure from the rest of the university, so that a lecturer in the medical school earns almost twice what a lecturer, although the job description is the same, but they earn almost twice what a lecturer or the rest of the university earns. That has really helped to retain staff. Now, how did we approach the development of the program? Of course, there had to be a needs assessment. There was a general needs assessment which had been undertaken by the government, as I've already alluded to, for training doctors locally. And now, as a department, we also had to do a targeted needs assessment, which had to satisfy university criteria for the need and sustainability of the program. Amongst them, whether the program was going to respond to a defined social and economic need in the country, and would the program be sustainable. Of course, there was a social and economic need because we had a shortage of psychiatrists in the country, and I didn't put up a slide for the figures. Mental illness was really a problem. So the patients were there, they needed help, there were no psychiatrists, especially needed psychiatrists. So there was that social need which we satisfied. And then sustainability. We had to ask ourselves, was there going to be sustained student enrollment, at least for the first cycle? And the answer was yes. We did a survey which showed that there were medical officers who are really interested in psychiatry and had not decided to apply for psychiatric training because either they were married and didn't want to leave their families and go and train abroad, and also because of the neighboring countries, apart from South Africa and Zambia and Zimbabwe, the rest had no. They have no, up to now, they have no psychiatric residency training programs. So they will provide another source of potential trainees. So we did stakeholder consultation. After the department had satisfied that criteria, we did a stakeholder consultation, and then where we consulted psychiatrists in private and public sector, and members of the public, and then we also consulted other professionals like psychologists, social workers, and occupational therapists, and prospective students, and Minister of Health officials, and also relevant departments in the university. We had several meetings with them, and the need, we could see there was need, and there was great support for the idea of having a training for psychiatrists in the country. And then we did benchmarking now with some institutions, and in South Africa at that time we had consultations with BRICS. I should mention specifically Professor Ugasvari, Subramane, Subra. She was very helpful, and she sent part of her staff. They came, we sat together, we did a lot of benchmarking, looked at their curriculum. We also looked at the curriculum from the Royal College of Psychiatrists and from New Zealand and from the University of Nairobi. And we put this all together, and this helped us to develop a curriculum. We used Kahn's 6-step approach, targeted needs assessment, and so on. And then we also had some advantages in the sense that we already had the professional bodies that would maybe be having a look or referring our proposed program, so to speak. We had the Botswana Health Professionals Council, which had already provisionally accredited the other residency programs, and since the template we were using was similar to what was used for other residency programs in the Faculty of Medicine, it was just tweaking it, and then it would satisfy their criteria. And then for qualification registration, we also had to register with the National Qualifications Authority, and I'm glad to say we're in the 3rd year, and we have already gotten both the qualification registration and the program registration. So I should say, of course, I've not gone through the steps in great detail, but having done that, we advertised for intake in 2019, and we had an overwhelming response. We only wanted, our target is to enroll 5 residents per year, and we had 12 applicants for the first advert, and we took 5. And those 5 residents are now in 3rd year, in their 3rd year of the program. And we now have a total enrollment of 17 students. I know you are saying 5 plus 5 plus 5 is 15. I'll tell you why they are 17. The 2nd year, again, the response to our advert was overwhelming. And then we decided that so long as we could manage to supervise the students' dissertations and there was training space, we could increase our intake. So we increased and started now taking 6 instead of 5. So this is basically because we are getting more applicants than slots, and this is a trend that is likely to continue for the foreseeable future. Other achievements so far is that we have had an impact in our 3-year reign. Even if we hadn't had, I wouldn't say we haven't had, because it's a program and I have to brag about it. We have successfully lobbied for opening a child and adolescent unit at the main psychiatric hospital, and we have also lobbied, and there are plans now to open a specialized addiction unit in the hospital. And the research output by faculty and students is one of the best in the whole Faculty of Medicine. So how have we overcome our resource constraints so far? Collaborations. I must mention 2 people in this room who have been very helpful to us. That's Professor Chilisa and Professor Saida. Maybe you give them a hand. I didn't mention it, but one of the issues that we were going to face was we had no subspecialists in the whole country. And during the 2nd phase of the proposed training, the students have to rotate through subspecialty. Subspecialties like child and adolescent, neuropsychiatry, and so on. So currently, thanks to technology, our students are attending sessions with students from the University of KwaZulu-Natal, our residents. They have joint sessions. And the same thing applies to neurology. Don't worry, I know what I put there. The same thing applies to neurology. And we are also very actively recruiting adjunct staff. And the next slide was going to be, how can AGMHI, I think anybody who has ever been a lecturer knows that it's very dangerous to go with just your computer alone and without a hard copy. Okay, I'm just finishing. Okay. So I always get prepared. So how can AGMHI assist? You are a pool of experts that you can draw on. And we really we have an open advert for adjunct staff, which is out there. It doesn't matter whether you are a subspecialist or not, you are free to apply. For adjunct, the rules are not so strict as for substantive lecturers. So this is an appeal to you. I can send out the advert, and that's how we are covering. We are collaborating with before the lights went off, we said we are collaborating with the New York University and Columbia and UPenn. UPenn has been very helpful. So please apply to be adjunct staff. AGMHI can also help us with the research collaborations and reading materials, and you provide networking opportunities for both our staff and students. So, because my time is over, I would just like to say it is very possible to start a residency program despite resource limitations. When we started, we were 3 psychiatrists when we started the program. Now we are 5 plus 4 adjuncts. Thank you.
Thank you very much. And thank you for plugging the power of AGMHI and collaborations and UKZN and all the work they're doing with you and teaching.